Alvaro Diaz Gonzalez. I work at Marqués de Valdecilla University Hospital in the north of Spain, and we will talk today about primary biliary cholangitis. This is the table of contents. We will talk about the disease itself, the diagnosis, and also the treatment. First, let's start with the definition of the disease. Primary biliary cholangitis is a chronic autoimmune liver disease characterized by chronic inflammation which surrounds and destroys interlobal and septal bile ducts. If untreated, this condition is progressive and progression rates varies greatly among patients. This is the difficult definition of the disease, and we will explain it in a more simple way in the upcoming slides. Is it frequent? Well, in fact, it is not frequent. It's considered to be a rare disease. The real incidence is unknown, and what we know is that the prevalence is 4 times higher in women than in men. So, bile duct injury, what is that? First, it's important to know what the liver is and where the liver is. The liver is this organ that is placed in the upper right quadrant of the abdomen. This is the picture of the liver, and it's conformed by 2 main cells. On the one hand, we have hepatocytes that account for more than 80% of the liver, and the main functions of these cells are metabolism, detoxification, and also the formation of bile. On the other hand, we have cholangiocytes that are the epithelial cell of the bile ducts, let's say the skin inside these bile ducts, and the main functions of these cells are bile secretion and modification of bile. So the bile ducts, the cholangiocytes, have these cells inside the bile ducts, and then we saw that PBC, the main lesion of this disease, is the bile duct injury. Therefore, primary biliary cholangitis appears here. This is a picture of the anatomy of the liver. We can see here in blue the vein, in red the artery, and in green we can see the biliary tree. Here in the slide we can see the macroscopic view, let's say the big picture of the biliary tree, and on the right part of the slide we can see the microscopic view, the tail view. We saw before that the hepatocytes are those cells that are involved in the formation of bile. So this bile is released here and flows from the small bile ducts here, and they go this way to the large bile ducts, and then finally end in the small bowel. So finally, the important thing of this slide is to understand that the disease, the primary biliary cholangitis main lesion appears here at a microscopic level in the bile ducts that are responsible of transporting the bile that is formatted in the hepatocytes, finally, and in the small bowel. So how can we diagnose this disease? First, for diagnosing PBC, patients must meet 2 out of these 3 criteria. First, an elevated alkaline phosphatase above the upper limit of normal. This is a liver enzyme that is easily found in regular biochemical tests, in blood tests. The presence of anti-mitochondrial antibodies that are present in 90 to 95% of patients. And if these anti-mitochondrial antibodies are negative, the presence of other antibodies are enough for diagnosing the disease. And finally, the third criteria is a biopsy consistent with PBC. So just meeting 2 out of these 3 criteria are enough for diagnosing the disease. So is biopsy needed? As a general rule, it is not necessary for the diagnosis of PBC, and this is because the presence of anti-mitochondrial antibodies, AMA, and elevated alkaline phosphatase are enough for diagnosing the disease. So if most part of patients present anti-mitochondrial antibodies and elevated alkaline phosphatase in the setting of PBC, when is it really necessary? Well, in those settings where patients do not present these anti-mitochondrial antibodies, or they do not present other antibodies that we will see in the following slide, in the situation of high suspicion of overlap syndrome, and overlap syndrome, especially with autoimmune hepatitis, refer to the simultaneous presence of both diseases. In this case, it would be autoimmune hepatitis and also primary biliary cholangitis. And finally, another indication for biopsy is in the setting of high suspicion, but the remaining tests are negative. So moving to the new antibodies, that I mentioned before, this anti-SP100, anti-GP210, anti-hexokinase 1, and anti-KEL-12. These are antibodies that are easy to assay. They are easily analyzed from regular blood tests. They have a high specificity and increased sensitivity up to 75% in patients without antimitochondrial antibodies. And then this high specificity and increased sensitivity allow to avoid biopsy in a relevant number of patients. So really the need of biopsy for diagnosing PBC is not very high. So we know how to diagnose the disease, and the next question is, which are the most frequent symptoms of PBC? First, we have fatigue, pruritus, abdominal pain, and also SICCA complex. Well, fatigue is the most frequent symptom and appears in up to 80% of patients and really impairs quality of life. The cause of this symptom in PBC is still unknown, but it's a relevant symptom related to the disease. And it's important to talk to our patients, to ask them how do they feel, if they feel tired, if not, because although there is not a specific treatment for addressing fatigue, we can try to find some strategies in order to improve the general feeling. Another relevant symptom is pruritus. It is the second most frequent symptom and appears in up to 70% of patients during the evolution of the disease. It's important to know that this itching fluctuates. There are periods of getting worse, there are periods of getting better, and the origin of pruritus is still unknown. But it's important to know, as pruritus is a very limiting symptom that appears in a high percentage of patients, it's important to know the characteristics of this pruritus. First, it has a diurnal rhythm, and the highest itch intensity appears early at night. This pruritus may appear in the limbs, it may appear also in the palms of the hands, in the soles of the feet, and also it can be generalized. So let's move to the third most frequent symptom. In this case is the SICCA complex. It's frequent, although real prevalence is not clear. Most frequent manifestation, the most frequent way of presentation is dry eyes or dry mouth, but other symptoms may be dysphagia and also vaginal dryness. This means the difficulty to swallow meals, water, liquids, or whatever. And let's move to the fourth most frequent symptom. Although this abdominal pain is not a very frequent symptom, it appears in up to 17% of patients, and characteristically, this abdominal pain appears in the right upper quadrant, here of the belly, of course. It is not correlated with disease stage, it is not correlated with liver size, and often disappears spontaneously. So, before moving on, we know now how to diagnose the disease. We know that biopsy is not necessary in most part of cases, thanks to the presence of antimitochondrial antibodies or the new antibodies that allows avoiding this biopsy. We know also the main or the most frequent symptoms related to the disease, and it's important. I recall it's important to talk to our patients about if they feel tired, the fatigue, and also the itch. So let's move to the treatment of the disease. First, ursodeoxycholic acid is standard of care. It's a very effective drug and a very well-tolerated drug. In fact, we achieve a good response with this treatment in up to 60 to 70% of patients. The dose of ursodeoxycholic acid is 13 to 15 milligrams per kilo a day and can be taken once a day, one dose, or in a split dose. This drug should be taken preferably with meals, and if the patient decides or the physician decides to indicate this drug just once daily, it should be taken at bedtime. What about the safety profile, the adverse events? These adverse events are infrequent. As I mentioned before, it's a very well-tolerated drug, and the most frequent symptoms or the most frequent adverse events related to the drug refer to the digestive system, as these are nausea, vomiting, bloating, or abdominal pain, diarrhea, or constipation. Although they are very infrequent, they used to be mild and usually disappear with time. So I'm being treated with ursodeoxycholic acid. How can I know if it works? How can my doctor know if the treatment is working for me? First, it's important to know that biopsy is not necessary. As we saw before, in most part of cases, biopsy is not necessary for diagnosing the disease, and it is not necessary either for assessing response. The evaluation of this response is based on biochemical parameters, and this means we evaluate the blood tests in order to know if the patient is responding or not. And something that I consider that is very important to know for patients to know is that response should be evaluated 12 months after the start of the treatment, not before. However, I have to say that there are some works that are evaluating the usefulness of evaluating response earlier at 6 months, and the results are promising. But up to now, we must wait for 12 months in order to know if the patient is responding or not to the drug. So what about those patients that do not respond after 12 months? We mentioned before that 30 to 40% of patients may not experience a good response to ursodeoxycholic acid. And then we have different second-line agents that are indicated in patients without this adequate response after 1 year under UDCA treatment. These are obeticholic acid and bezafibrate. Bezafibrate, I have to say that this is a drug that it is not licensed in many countries for treating PBC. However, it's frequent its use as an off-label drug. So let's start with obeticholic acid. This is a drug. The dose of obeticholic acid is 5 milligrams during the first 6 months, and if the patient presents a good tolerance to the drug, it can be increased to 10 milligrams thereafter. This drug should be taken once a day, and it can be taken with or without meals. What about the safety profile? Obeticholic acid presents a particular safety profile. In fact, pruritus is a very relevant adverse event that may appear in 1/3 of patients with this treatment. However, it's important to point out that only 10% of patients have to discontinue the drug because of pruritus. Usually appears in the first 2 weeks and lasts for 3 months. And it's important to know that usually this pruritus that is induced by obeticholic acid improves with time. So it's important to talk to our patients before starting the treatment that they may experience pruritus related to the drug, that it probably is going to get better. And if they are able to tolerate it, obeticholic acid is a very good drug in order to control their disease. So it's important to talk and explain this potential side effect to our patients before starting the drug. Other symptoms are fatigue, liver decompensation, nausea, and nasopharyngitis, but these are infrequent. Let's move to bezafibrate. This is a drug that it's indicated 400 milligrams daily and should be taken once a day during or after meals. Referring to adverse events, the most frequent ones are related to muscle, myalgia, and also creatine kinase elevations. Also, it's described a mild elevation of creatinine. Creatinine is the way that we measure the kidney function through biochemical parameters using blood tests, and also diarrhea and abdominal pain. So these were the options for treating PBC. We have the first line with ursodeoxycholic acid, effective in up to 60 to 70% of patients. In those remaining 30 to 40% of patients who do not respond, we have obeticholic acid or bezafibrate. But what about those patients that do not respond to these second-line drugs, or who cannot be treated with these second-line drugs? Well, this is probably the place for clinical trials. And what is a clinical trial? Clinical trials are research studies performed in people that aim to evaluate a medical, surgical, or behavioral intervention. In some scenarios, they are the way to find out if a new treatment is safe and effective in patients. So, in some scenarios, clinical trials represent the opportunity to benefit from a potentially effective treatment before being widely available. The phases of clinical trials, there are some others, but I focus in the slide in phase 1, phase 2, and phase 3. Phase 1 clinical trials evaluate human safety. Phase 2, they evaluate extended safety, and also they test the first data, they obtain the first data about efficacy. And phase 3, they evaluate these phase 3 clinical trials evaluate efficacy, dosing, and safety. In fact, we have obeticholic acid and bezafibrate available as second-line drugs thanks to clinical trials. In fact, obeticholic acid was proven to be effective in this clinical trial, phase 3 clinical trial published in 2016. And the same was for Bezafibrate in 2018. We have these two drugs available thanks to clinical trials. And it's important to know that clinical trials are the way that medicine or the discovery of new drug works. If we didn't have clinical trials, probably we could not show the effectiveness. We could not test the effectiveness of new drugs for treating not only PBC patients, but also patients with other diseases. And just before ending, I want to show two examples of clinical trials and referring to two ongoing clinical trials. In this phase 2 trial evaluating elafibranor against placebo, they included 45 patients, and the results showed that this drug was safe and seemed to be effective. And this is the aim of phase 2 trials, evaluating safety and also first data about effectiveness. And then, because of these results, the researchers decided to run this phase 3 trial, and we expect to have the results in the upcoming years. And the same goes for these phase 2 trials, seladelpar against placebo. They included 38 patients, and they saw that the treatment was safe and also seemed to be effective. This is the aim of phase 2 trials. And then the researchers decided to run the phase 3 trial, and we expect to have more information in the next years. For concluding this presentation, primary biliary cholangitis is a progressive disease that requires early treatment. Ursodeoxycholic acid is the standard of care. It's an effective and very well tolerated drug. There are effective alternatives for patients without an adequate response to ursodeoxycholic acid, and clinical trials may represent an excellent opportunity for early access to potential effective drugs. Thank you very much.